And so it was a very easy ROI. So we basically looked at all of the medical expenses for the patients enrolled in the active diabetes program, looked at all place of service, fee-for-service fees, everything. And then we compared that to a cohort of patients, A1C greater than 8, not enrolled in active diabetes. And what we found is that we were able to save almost $1,200 per patient per year in the patients enrolled in active diabetes. That's a wonderful ROI. However, when you subtract the cost of the program, because you've got to pay the staff and pay the rent, because we're an IPA model, so we pay for everything, just like the IPA physicians do. The savings was close to $100 per patient per year, much less, but still positive. And all we had to do was to prove that it was positive. It could have been break even, and the organization would have continued to fund the program. But the fact that it was a little bit positive, we got the thumbs up, green light, keep the program going. At that time, I think we had about 350 patients or so enrolled, and the goal was to get it up to 500. So obviously, the more patients you have, the better the ROI. And of course, there'll come a point where you have to hire more staff, and then you'll have to up the number of patients again to accommodate the salaries for the new staff. So, so that's how we calculated the ROI. And in terms of lessons learned, there was a lot. So I'm just going to summarize to some of the major ones. So again, Kristi talked about having PCP buy-in. So we started with, hey, we have this great program, we have this grant, and we have this great team in this beautiful facility, and we just thought the PCPs would be lining up, but they weren't brought in at the ground floor. They didn't know what we were talking about. They were not super enthusiastic. Of course, that's all worked itself out, as you can tell today. But I would say, if you were going to start a program like this, to try to get the PCP community to buy into it from the get-go. You don't need a huge team, but you do need the right team. We think the team that includes the clinical pharmacist, the clinical social worker, and the dietitian. So someone to adjust and monitor the medications, somebody to help the patient with nutrition decisions each and every day, and someone to help the patient deal with all of the issues that comes along with being a diabetic. That's who you need. You will fund the program through the lowering of medical expenses, and there may be another way to fund it, and so and we can talk about more if you have questions. But so we are participating in a pilot with Blue Shield, where they're actually paying our pharmacists for comprehensive medication management. They're paying us for the HMO population, the senior population, because that helps with the 5-star, so there's funding there. And so it's not enough to pay for the pharmacist, but it helps offset some of the costs. So more to come on that. Again, I think every organization is different, and some organizations are looking for, 5-to-1 ROI. Well, that's unreasonable, but if you could convince the organization that this is the right thing to do, and as long as it's break even, then the organization should be supportive of that. And I think the last thing is that, we all are multitasking, doing so many things every day, but if you're going to start a program like this, that, you just really need to insist that this is the one thing that you're going to focus on until you get it going, and it's a well-oiled machine. That's a year at least of time. So if you focus in on this one thing, then we think it'll allow you to do it well. So that's it for our high-level overview of the program. Thank you for your time and attention today. So now we'll open it up to questions. Should anyone have questions?
Can we start with Dr. Kohatsu?
Thanks very much for that great presentation and going into both the clinical and the practical aspects. It's really helpful. And toward that end, of the denominator of patients with diabetes, and you had a threshold of hemoglobin A1C over 8, And I think you also said some of the harder to reach patients. Of those who might benefit in your catchment area or defined population, what % are willing to do the commitment of signing up for the program, or do you have any idea? Even a guesstimate, like, is it a small percentage? And if you don't have that percentage, I'm thinking, how do the participants compare with the general population of those who might benefit, just to see who's signing up for the program?
I don't, can you hear me? I don't think we know the percentage. I will say that in the beginning, when we were doing the cold calling, it was a very small percentage of patients that was willing to participate. And that once we got the PCPs and their office staff to buy into the program, then it was a much larger percentage. I imagine there's still some patients that don't make it to us because the PCP has pitched the program and they're not interested. And maybe it's a pitch over time and they finally become interested. So, yeah, you need good salespeople, if you will, to get patients interested in the program. And then your other question?
Oh, just to add on to that percentage that is referred to us. So we see all the patients that are referred, and we encourage the office staff and the PCPs to give our information to the patient to have them make a call to us, but we don't wait around for them to call. So if we get the referral and it's been 2 or 3 days and we don't have the patient on our schedule, we reach out to them. And out of the patients that we reach out to and that have been referred, I'd say about 90% do come in. Like Andrea said, we do have some that are like, yeah, my doctor told me I'm just not interested right now. But we just tell them, look, we're here, you change your mind, and we let the physician's office know, look, Mr. So-and-so declined, we just want to let you know.
When
Kristi,
starting a program like this, you mentioned a team could take care of a number of people. How many patients can one team care for? You started out with 15 patients and you built it up. What is the max? So 3 was your sort of ideal team. How many diabetic patients do you actually take care of for that team of 3 before you have to think about expanding?
We have more than 500 because the number that I'm including is just the patients that are being seen by the team. Our dietitian has a whole nother list of patients that she sees only for diet education, which is probably about 200. So I'd say we can see about 500, 700 with our 3, knowing that there's some patients that are only seen by the dietitian.
So one 3-person team could handle 500 to 700 for that. So we know how many FTEs we would have to come up with for that. That is great. Now the other is, you mentioned in your program that you're looking at A1C. As far as cost effective, did you have available to you continuous glucose monitoring, and did that seem to be cost effective in your group of population or not?
We currently do not have CGM in the clinic, like if you're talking about the professional device that you can give the patient. We haven't got to that yet, but we do have glucometers available in the clinic of all the brands that are covered by all the plans, because our patients are different insurance. So each patient will get a glucometer and we teach them how to use it and bring back their numbers to us. But we are talking about CGM for the future.
Great. We had another question? Yes.
Hi, I'm Kristi Robinson from Kaiser Permanente here in the North Valley. I was interested in understanding a little more about how you're tracking the long-term success of your program. So I understand the patients are enrolled in the program, they get treated and evaluated until their A1C is stable for 12 months, and then they graduate from the program. How do you assess whether that training and those teachings have really stuck with the patient and they maintain their good A1C long-term?
Well, I can speak to a little about that because, of course, once they graduate, they come back to the physician. And then we go back to our usual routine, having them come back in every 3 months and making sure we're reinforcing what they've learned through diabetes. Now, that doesn't always work, and sometimes they become eligible again. Their A1C goes up over 8%, and we send them back.
Are you tracking statistics or not yet?
Yeah, it would, it's enough to track our 700 patients right now. So ideally, we would be able to track the afterwards and look at what's happened. It's just hard because patients move away, they change providers, they change insurance. So I guess it's just hard to work that out with the data right now.
We have just hired a data scientist.
Okay.
And boy, does he have his plate full.
And comparing it to your control population, people who are not being managed and they're,
So we're, again, as an IPA, we just don't have like the resources of a Kaiser to have, like a pop health medical director to monitor that. So that's not something we tracked, but it's a great question, and it'll make us go back and start trying to figure out how we can best monitor that going forward, because we should have an answer to that.
And just one other question, does your social worker support any other programs besides diabetes?
They act as a case manager.
Yeah, so she is part-time with the diabetes program, and she also does case management, and she supports our, we have a post-discharge clinic as well, and so she'll occasionally cover and support that too.
So one of the concerns we've always had with diabetes is the increasing cost of insulin. Were you always able to get the best insulin available for your patients, or did you have to sometimes compromise and take a lower cost prep even though it wasn't quite as convenient?
Yes, we do unfortunately have to compromise with the, we know that Walmart has like their kind of, their own brand of NPH&R insulin, so that's low cost, it's $25 a vial. So especially for the Medicare patients that are in the Medicare gap at the end of the year, which is closing and it seems to be improving over time, and there seems to be more resources, but that is an option sometimes at the end of the year. We have to let patients know that they might have to switch insulin and then switch back when January comes.
Yes.
Dave Herbert here from Southern Independent Physicians. Just to give a slightly different twist on an IPA who's done something similar. We're a local IPA here in Sacramento area, slightly smaller than you, but not too much. And Hattie gave us an award this winter for our diabetes control, where our patients continue to be above the 90th percentile in terms of our A1C control. We have a program very similar to yours. We collaborate with the big Sutter program, so we don't have to buy our own. We contract it from them. The diabetes education is done in person, but everything else after that is done telephonically. And so the other change that we have done that I didn't hear from you is that if anybody has an elevated A1C, they're in the program. Our program gets the lab results and automatically enrolls them. Now, not that every patient agrees to remain in the program, but that's been one way for us to increase our enrollment and our success.
Hi, I'm Joan Moreland. I just finished 37 years as a diabetes educator, so I have a lot of empathy for what you've gone through. I would like to just say to the people in the room to really listen to what you said. I can see why your program is successful. It came through to me that your program is put together for the patient, and that you really care about them. And that's what keeps them coming back as much as anything, is what I've found. All too often, diabetes is for 100 years been used as an example of writing up a class for patients, because it lends itself to organization. And we find that so many classes never get off of the paper and get to the patient. It becomes rigid and demanding. So I think, you are your own success. It's really, was a good thing to hear. I will drop one caveat in. I participated in a program about a month ago doing screening, or not screenings, but checkups on diabetes. The plan isolated 700 patients out of control. A1C is very, very high. And they were offered to come in and get fundus photos done, and they would get a $25 gift card. And they were offered to also have a mammogram, and they would get a $50 card for that. So that's $75. And you know we had fewer than 100 out of the 700 show up. So it's not the fancy equipment, it's you guys. I mean, that's your success. It really is. I applaud you.
I have two questions. My first is, how are you addressing cultural sensitivity in terms of language and foods?
So we don't have a wide range of different languages that we need to cover in our population currently. I speak Spanish. I have another pharmacist that speaks Spanish. We have pharmacists that speak Chinese and Vietnamese. So that's helpful, and that has pretty much, we've been able to cover the language barrier that way. And our dietitian, both of them are really good about providing meal plans or, individual diet modification based on culture and, even going beyond that, like social background, like and what the patient can afford. We've found that for some of these patients that are elderly, they can't get out of the house to grocery shop, that we've been able to sign them up for Meals on Wheels, and they give diabetes portion control as well, and that's been a huge success if we can get them enrolled in that as well. So I feel like our dietitians are really aware of the different diets according to the patient's culture and background, and they are able to address that really well.
And is that education just with the patient, or do you include the extended family or caretaker?
Yeah, we always appreciate when the family can come in, especially whoever's doing the cooking. So we always want the extra person to come in, whoever is doing the cooking in the house. And a lot of times the other family member has diabetes, or they have children, and it's like, oh, we want them to be starting that healthy lifestyle so they don't follow in the same path. And we try to emphasize that with the patient. It can be hard. Sometimes the patients don't want their family to come in for some reason. It's hard because they're on them all the time. So that's where the social worker comes in too, helping the family dynamic and balance that. It's tough though, it is.
And I'm sorry, I have two questions. In terms of the coordinated care, who handles that in terms of somebody who might have cancer or some other illness?
Yeah, that would be our social worker. And she does a really good job. We've had her to on a hospice, and she's really good about coordinating that, and again, the family members.
So I want to commend you for being able to deliver one-on-one patient care to 500 to 700 people. I think I think that's quite impressive to be that effective. And clearly the one-on-one was part of your success, I think, because if a patient knows they're coming in to see a particular individual, they're really motivated to keep that appointment and follow up with it. So that was great. I also noted that your nutritionist was delivering the exercise program. For the exercise, did you have any organized program to refer patients to? Or did you just tell them to do their own exercise program and come up with a schedule? Or was it just to encourage them to do your 30 minutes of exercise every day, whatever you can fit in?
Yeah, so usually, as far as when the pharmacist, we kind of all talk to them about exercise because activity is so important. And we really try to hone in on what they can do. So sometimes patients are like, yeah, I got a gym membership. Oh, okay, well, how many times have you gone? Well, I haven't gone yet. I'm thinking about starting next month because I'm going to be off of my job. I'm a teacher and summer's coming. So we try to encourage them, like, it's not about waiting, like what can you do now? Like what do you have, 10 minutes? Do you have 15 minutes? Do you have 20 minutes? And we try to encourage them, what's the best time of day to go out for a walk? Oh, well, I have a new bike, I guess I can start riding that. And then we follow up with them, in a week. Okay, did you ride your bike? How many times did you ride it? Because it's, again, about the baby steps. Some patients are like, I'm gonna train for a marathon, in 2 months I'm gonna start. And it's like, no, but we need you to start today. So we don't have an exercise program that our organization has that we can refer them to. That would be great if we did, but again, it's all about time and what the patient can do, and a lot of us just don't have a lot of time to carve out for that. So to make it.
Can I just ask for what other health systems are doing about the exercise piece? Is anybody teaming up like with YMCA? Yes.
So we're not pharmacy involved yet, but I do know North Bay has exercise medicine. So we have a wellness center that the physicians can actually prescribe the patients to go to the wellness center and work out with physical therapists and trainers.
And we do the same thing at Barton. We have a wellness center that opened up a year ago. And so we've got a team of physiologists and trainers, and it's worked fairly well. We'll be describing some of that in September when we have a webinar.
And the date of that is what, the 18th of September, and I forgot to announce that, so if you could say a
The
little more.
18th of September, so the Healthy Hearts California, a regular webinar. Dr. Bergner, who is at Barton Health, is our wellness doc, and he and I will be just presenting. It'll be similar to the presentation we had last September. It was last September here at RightCare Initiative.
Yep.
So exactly a year later, have to update I'm updating my slides. But we'll be giving that 10 o'clock in the morning. You'll probably get an email and you can register for that.
One of the difficulties with exercise rehabilitation or programs is there is not reimbursement for primary prevention. And so any program you would refer them to, there would have to be someone to pick up the funding for it. Now, we do have the ability at our program for someone with a prior event or an intervention, then there is CMS does pick up costs for that, and we can roll that in. And if you have enough CMS patients to pay for the program, you can sneak in others who are not qualifying for that and do them for no cost at that point. The difficulty is to run an entire program with no reimbursement now does require FTEs and physicians and space and rental, and it becomes more costly at that point in time. That's why your program does what many of us do. We refer the patient to a program that they can do at home where it's available to them, or that they can do with minor fees as far as the exercise program for it. But it is a vital part both of pre-diabetes to prevent the development of diabetes. It's been shown to be more successful than even metformin in preventing people from going on to type 2 diabetes. And it is certainly a valuable part of the comprehensive program for any diabetic management program.
I will also say that there are health plans that cover gym memberships, and our patients will even say that, well, I know my health plan might cover it, I should look into that. Yes, let's look into it, let's try to figure this out. So there are health plans that cover it, and sometimes that just needs to be like a little bit of a push for the patient too, like it's going to be a little cost.
And there are employers who cover it, and I think you mentioned that Boeing was a prominent in your area. Do they pick up any of these costs as an employer?
They have, actually one of their quality metrics, aside from A1C, less than 9 is BMI, and part of the part of the metric is that you've made a referral to either Weight Watchers or something like that, but they have a place that you can refer their employees to as well. So yes.
I'm just curious, Kristen, with Kaiser, do you have an exercise program related to diabetes?
No, I think there's a discount, for our Senior Advantage patients, for gym membership, but not specifically for diabetes.
Question from the back?
Yeah, I just had a logistical question. When you enrolled patients into the pilot, did you focus on Blue Shield patients only, or did you just scan across all payers?
It was across all payers.
Any other questions? We want to thank everyone for coming out today and their commitment to this. Diabetes is a big aspect of cardiovascular disease everywhere, especially in California. We estimate that if we get to about 2050, if we ever survive that one, there will be about 1 billion diabetics in the world. So there are a lot of them out there, and we need a lot of programs like this to, in fact, reduce cardiovascular disease for that. And Hattie has some additional announcements now on the way out to light up the rest of your afternoon. But thank you for coming today. We appreciate it. I'll turn it over to Hattie.
I just want to, before we all part, I want to say that there's something really, really big coming in the form of low-cost continuous glucose monitors. We had at our Los Angeles group, the head of diabetes for the University of Southern California, present extensive data. I've been trying to get her to come back up here. She's been here a couple of years ago, Dr. Ann Peters. And she presented the idea that in the future, instead of just tracking hemoglobin A1C, which is a 3-month or so average of the blood sugar levels, that what's really important is trying to keep the wave of what's happening with the patient's sugar as flat as possible using the continuous glucose monitor. So she showed that with this quarter-sized device on your shoulder, you can pair that with an iPhone. And she basically said it's been revolutionary for her patients, her pre-diabetes patients, as well as her diabetes patients. And she said she's so excited about it, she has her whole family on it, and even her dog, so she can understand how blood sugar works better. And she said what was so amazing to learn when you use this much more extensively, and it's, you know, it's all over the popular press now, but she's one of those that tells us things before they happen, that you really can see such a difference in how individuals respond to different foods. So she, as the head of diabetes and working on international diabetes guidelines for many years, has learned a lot because of this device. So she said they used to tell all their patients to have oatmeal for breakfast. And now she sees that for many patients that's problematic. And so, you know, protein really critical before carbs, and Joan could tell us about this, but they now have the data about that, and I just want to tell you a real positive story about it. My best friend at the Kennedy School of Government has a brother who's a type 1 diabetic, and he has been in and out of hospitals and emergency rooms, causing lots of family disruption, drama, and pain, including her own husband donating his kidney to her brother. Because he did not want to wear a continuous glucose monitor because he's a sort of a, I don't know, it's a vanity thing for him. It's about not wanting people to know he has diabetes. So the old monitors were evident. Now this new monitor, you can wear